Hi there, and welcome to the Surviving and Thriving in Residency podcast. I'm Charley Lowry, your host and director of GME Relations at PracticeLink. This show is all about exploring the world of graduate and undergraduate medical education. We'll dive into the real-life experiences, successes, and challenges faced by medical students, residents, and fellows, while also highlighting valuable tools to support you, whether that's financial planning, student aid, or the many free resources provided by PracticeLink. If you're thinking about med school, currently studying, or deep into residency or fellowship, this podcast is here to offer insights and support to make your journey a bit easier than those before you.
Hello and welcome to Surviving and Thriving. Today I am very happy to have with us Kyle Claussen, the CEO of Resolve. Kyle, welcome to the show, and I'd like to kick it off. If you would, tell us about Resolve and a little bit about your background and your journey to being CEO of Resolve.
I appreciate you guys having me on, and I always like to talk about Resolve. So that's the easy part. Resolve exists to empower physicians, and especially young physicians, with education and mostly tools, right? And help around one very specific area, which is compensation and contracts. And we know that that has really high value for especially those residents and fellows that are coming out. But we also know that it's an area that there's not a ton of education on. And so our business was formed by a physician to try to solve that very specific niche. We've been doing it for probably 15 years-ish now, and love pretty much every day. Not every day is great, but pretty much every day we love what we're doing. So that's what Resolve is and who we help and what we do.
That's great. Yeah, that's incredible. So our audience will hopefully gain a lot of information from this podcast. We're going to be talking today mainly to medical students, medical residents, but really anybody pursuing a journey in medicine. So contracts can be very, very scary, I'm sure. So let's just talk about some questions that folks may have, some commonly asked questions that residents might ask you. So we'll start with, I recently received a few offer letters for different jobs. Should I sign these letters before reviewing the contract? And does Resolve review offer letters?
We do, and we really would prefer to review them for every single client. Sometimes clients will come in and they'll have already kind of gotten past that stage. And so my recommendation is to every single resident that's out there, you're going to have multiple offers, right? I mean, you're in a spot where supply and demand is definitely in your favor, right? There's more jobs out there than there are physicians. And so when you're looking at letters of intent, usually those are going to include details around compensation, right? Kind of the high level terms. It's not going to be a fully fleshed out contract. It's not going to have 30 pages. It's usually like 1 or 2 pages. And so you do want to review those. You do want to make sure what you're signing off on is fair, especially on the compensation side. And so if you happen to do that, right, you happen to sign a letter of intent before negotiating it, and you try to come back later, most employers don't like that. I mean, they feel like they're going through this process in good faith, hopefully, and you should be too. And so it puts you in a better position to say, hey, if I need to make an ask on a signing bonus, or I need to make an ask on a conversion factor for my dollar per work RVU, I want to do that as early as possible once I see those numbers.
What advice would you give somebody? I think a lot of people, when they're put on the spot, some people have a hard time saying no or being assertive. What advice do you give those folks who are sitting there in the moment and might be tempted to sign something just because of maybe their personality? Or does that make sense?
It does, yeah. And that's, I think, a common personality trait of physicians. They want to be agreeable, right? They train to help people, right? And so it's difficult sometimes to advocate for yourself. But what everybody's after is fairness. And so I think if you go into the conversation with that type of attitude, it's not that I'm just asking for more money to ask for more. It's that I want to be paid fairly for what I'm doing, as opposed to what the market is offering for my services at this point in time. And in every specialty, there's variation. So we know that orthopedics and family medicine don't earn the same. The dollar per work RVU is different. The total compensation is different. But even within a certain specialty like family medicine, different geographic areas have different reimbursement rates, and some are harder to recruit to than others. And so you'll see that in the economics of the document come out. And so if you go into it with this idea that, hey, I want to be paid fairly for my specialty, for this area, now we're talking about a range. We're talking about fair market value is not a set number, but it's a range of numbers. And so then you can get into a more business-friendly conversation sometimes, and we're disagreeing on a range rather than disagreeing on a huge number. So that's my recommendation, is you have to be comfortable asking, you have to be educated, understand the data, know what you're looking at, know that you are making a good faith ask. And I think it's a lot easier when you do it that way.
Good deal. So let's see. Another question here would be, I've been told my contract is non-negotiable. Should I still try to negotiate? And will an employer make exceptions?
I have a skewed view on this one. Obviously, we want you to negotiate. We want you to get the terms that are important to you. And the reason that we think that is not to be difficult to health systems, in and of itself, I think sometimes it might come across that way, right? As my attorneys being adversarial to the employer. What we're looking for is a document that reflects the deal. So that way, hopefully, it's a long-term relationship. And the systems want that too, or every employer, even if it's private practice, they want that. So if we can document things the right way, those details are usually different for every single doctor, right? I mean, some aren't working Fridays, right? Some may have different call schedules. Some are allowed to do some outside activities and others aren't. And so those details, even though there are standard contracts and boilerplate language, we think it's really important to get the details right for you individually so that way you are satisfied long term. So as a starting point, every employer is going to say, this is our standard contract. We never change it. We never negotiate it. That's rarely true. Usually they will make some adjustments because they do want to get you to sign. I think you just, again, have to go about that in good faith and know kind of what you're asking for and make sure it's things that are of high level importance to you and not nitpicking every single line right in the document.
Gotcha. How does contract negotiation differ if you have clinical experience and are not right out of training?
Well, anytime you're coming out of training, or you're just moving from one employer to the next even, there's this question on how much volume you'll produce, like what's your patient panel going to look like and how many work RVUs will you end up producing or what your collection number will be. And so if you've been in practice for a while, you've got some of that historical data. You can say, hey, if there's X number of patients, right? I mean, this is how efficient I am. This is what I'm getting through. This is what my collections look like. I do think you have probably, hopefully, knock on wood, a little bit more ammunition to say, hey, I don't want to be paid at the 40th percentile or 50th percentile because I've been producing at the 80th for the last 10 years. I expect to be somewhere in that neighborhood. And it'll give the employer confidence as well that assuming they have the volume for you, that you'll come in and produce and it's less risk to them when offering those higher compensation packages. So I think there is some nuance, there is some difference there because of the data, because of your track record that you can bring into the conversation.
Okay. How do I know I'm not asking for too much when negotiating compensation in a contract?
I think this is where having access to information and transparency around that is so important. So when we think about what is fair market value, there's certainly some surveys that are out there. MGMA is the one that we utilize with our service, but there's also Sullivan and Cotter, AMGA. There's some other ones that are out there. And so you have to have access to that information because your employers are going to negotiate off that. They use that for compliance and fair market value, Stark compliance and IRS compliance, things like that. So you have to know so you can make as close to an apples to apples comparison as you can. You also want to make sure, hopefully, you're using places like PracticeLink and getting lots of job offers. So that way you know what the market is today for you individually. And then hopefully if you're also utilizing services like Resolve, where you're on our site, you're seeing other contract offers and getting some of that market intelligence of what's happening. Even if I don't have 10 offers, I can go look at the hundreds of other offers that my colleagues have had. I think that's how you know. That's how you know if you're making a good faith ask or not, is because you're going to say, okay, I've looked at all the data. I know that this is within range. I know that it's not completely out of line to ask for this signing bonus or this increase in base salary. And so I think when you do it that way, it's a lot easier to be confident about what you're asking for.
Sure. Can a call schedule really be negotiated? Is scheduling something that employers will often change?
We actually just did one of these this morning. So call is one of these touchy subjects, right? So for some specialties, call is a lot more onerous than in others, which means if it's more onerous and a lot more frequent and heavier, that it becomes more of a deal breaker sometimes for people. And so if you're walking into a situation, let's say it's OB, where there's a lot of call, and there's maybe 4 or 5 people in the pool right now, but they've had a lot of turnover in the past. And so generally they may share call equally, but you might say, hey, I'm never going to be comfortable with more than 1 in 5 call. Right? I just can't for my personal life, whatever it is. And so even though your language is standard on that, I want to cap it at that rate. And it's not to say that I won't help out in an emergency situation. I just want to make sure my default rule is that I don't have to. And that's important for a couple of reasons. I mean, one, it's the deal you're walking into. It's what they've sold you the job on. It's probably what they told you in the interview. But also, life happens. Sometimes people quit and leave. Sometimes people get in accidents and they're disabled for a while. Sometimes administration changes. You have a new hospital CEO that didn't negotiate your deal that's now trying to look at your contract to decide what the obligations are. And so we just think, again, detailing that, whatever you want, maybe you're okay with 1 in 2 call because you get paid more. Maybe you want 1 in 10 call because you want quality of life. I think both of those things are fine. You just got to make sure that it fits your situation. So the answer is yes, you can negotiate call. You can put limitations on it. It just needs to fit you individually.
Great. So something we always talk about with residents when I go to visit residency programs that sometimes shocks the residents is when I tell them, you need to start this job process 18 months before you finish up. I always get a lot of shocked looks, a lot of blank stares. And part of that is because of negotiation, because of credentialing, all this stuff at the end. So a good question would be, how long does contract negotiation typically take? And what does the process look like?
I'm going to focus on for residents and fellows because those tend to be a little bit, I'm going to say a little more streamlined. If you're in a practice and you're renegotiating, sometimes they can drag out. I mean, we've had them last, a year and a half at times, which is really long. But the most typical cadence for a resident or fellow is that you're hopefully 12 to 18 months prior to you started your job search. So you've done that homework, you've gone through the interview process, and now you've got a document in hand. So from the time you get a letter of intent to the time that you're fully signed off is usually between a month and probably 2 or 3 months. So we don't usually see it go much beyond 3 months. But when you think about the other things that have to happen after your contract is signed, like credentialing, licensing, moving, if you're on any type of J1 waiver, there's immigration things that have to happen. And so we think that if you wait too long at the start, all you're doing is kind of walking yourself into a corner and reducing the leverage you have and the decision-making kind of stress component that you're going to place on yourself is really something you don't need to do. Just start early, make sure you know what your options are, and you can go through that process at a good cadence.
Yeah, because I think even 3 months would shock some folks. If I were to tell them, hey, this is going to take 3 months to get everything in order, it really does surprise them.
Physicians, have you finished training and now you're job hunting? PracticeLink.com's Resource Center is packed with free tools to help. From creating your CV, interview prep, and even tips to ace that site visit, we've got you all covered. Visit PracticeLink.com's Resource Center today, and while you're there, create your free account to connect with employers and view exclusive job opportunities.
How about, can I renegotiate my salary before my contract renews? And how do I go about that?
This is another fairly frequent misconception, I'm going to say, of physicians, is that they'll sign a contract for 3 years, for example. And so they think every single term is locked in for 3 years. I can't come back, right? It's not legal for me to come back and even ask for a change until that happens. The reality of the situation is that most of those are not actually 3-year contracts. So they have what's called a termination without cause section in them that basically says either party can terminate this on 3 months notice, right, or 90 days notice. And the contract is just evergreen. So it just constantly renews over and over and over until somebody raises their hand and says, hey, I think the market has shifted and we need to renegotiate this. Now, I can promise you from experience, if the market goes down, the hospital will come to you with an amendment that says, hey, reimbursements just fell a lot, or COVID's happening and we can't pay, we need to furlough, whatever it is. Those are real things that happen. And so I think it's also fair for physicians to say, okay, I'm paying attention to the market. I know comp is up 10% for my specialty from 2 years ago. I want to renegotiate, even if it's not technically the end of my term, but that's going to require you to pay attention and to raise your hand, because if you don't, it's still a business. I mean, they love to keep their labor costs 10% lower if they could for another year or two.
Great advice. And I think you're right. Yeah, the hospital, if things are in a downslope, they're definitely going to be on that pretty quick.
And I think you'd probably expect them to, right? I mean, I don't think that's a bad trade. I think it's just, that's the reality. And so you have to also take that side for yourself that says, hey, if the market's going up, I need to stay with the market.
Yeah, exactly. Okay, so I am philosophically opposed to signing a contract with a non-compete clause. How do I negotiate with employers to consider employing me without a non-compete? Now, a lot of folks out there listening may not even know about non-compete clauses. So you may want to talk about that just a little bit if you want to.
We certainly can back up and give some context around that. So what a non-compete clause is it's a paragraph in your contract that says once this contract is over, you're not allowed to work and compete with us within a certain mile radius, usually. And so it'll say, like, for 2 years after termination, you can't work within 20 miles, for example. That's obviously problematic for some people. And depending on how big that radius is, it could be 1 mile, it could be 100 miles. It's going to be different based on kind of how densely populated the area is that you're living in. But it can really remove you from an entire city. And so if you're thinking, hey, I'm going to go and settle down here and I've got kids in school and I've got a spouse with a good job, if you have a non-compete that says you can't work as a physician for 2 years, that's usually problematic. So I think it's a really good question. I think it's something you should be paying attention to. Something that's gotten a lot of attention nationally over the past year and a half. The FTC came in and tried to wipe these out, not only for physicians, but for everybody, and just said, hey, we think this is anti-competitive behavior and we think that they're just bad for business, and so we should do away with them. That then got overturned in the court system. They said it was too broad. The FTC was going to challenge that, and now they may not challenge it. And so at this point in time, every state gets to decide whether or not these are okay for physicians and whether or not they're reasonable. And there are some states, about 10, maybe a few more, that have put limitations on non-competes for physicians, but it's very, very specific. Sometimes it's a time limitation, sometimes it's a geographic limitation, sometimes there's income limitations, right? On if you earn less than a certain amount, won't apply. And so you have to be really careful on these because we find that they reduce a physician's ability to renegotiate, and they also potentially are going to wreck some family dynamics for you if you have to move or at least do locum work for 2 years while this thing runs out. So a point to be very, very careful on.
I could see that being a major issue when you're buying a new home and you have a house payment and kids in school and huge financial strain for sure. Some employers restrict employment at another place. Is it normal to negotiate out of this? For example, I'm planning to start a Botox, injectables, infusion business on the side.
This is a reference to what we call the outside activities section of a contract. And so it's not uncommon for an employer to say, hey, while you're working for us, while we're paying you, we expect your full-time attention and kind of exclusive relationship with you. For the most part, I think that those are fine as long as you have the ability to work outside of that. So if it's after hours, if it's on off days, if it's on weekends, that's where we don't like those restrictions to come into play. And often that language starts out being extremely broad where it covers everything. It covers what you do at 9 o'clock at night, and we don't want to apply to that. So I think if you can limit the language and say, hey, if it doesn't materially interfere, I should be able to keep the revenue from it. I should be able to do it. It certainly doesn't want to be competitive, right? I mean, you don't want to be establishing a business in your 5 to 9 that's going to then turn around and take patients away. I don't think they're going to go for that. But I think if it's not competitive with them, if it's not interfering with the job, I think you've got a pretty good leg to stand on to say that that's a reasonable request.
And this is something that's probably a lot more common now, right? You're probably seeing more of this now than ever.
Yeah, I think we've been doing this for 15 plus years. In the last 2 or 3 years, side gigs and the outside activity piece has become much more important for the younger physicians than it was 10 years ago.
Yeah, I see a lot of it myself, just with the physicians I know. It seems like a lot of them have a little side hustle going on as well.
Well, it applies to even things like social media, right? I mean, there's a lot of side work. It's not just always patient-facing things. It could be consulting. It could be being an expert witness, right? I mean, there's a lot of side revenue that's out there taking surveys. And so you just want to make sure you're not potentially doing things that you're going to have to turn the revenue over to your employer on. I mean, nobody wants to do that.
Yeah. Does the non-compete apply if I am changing positions? For example, from clinical to administrative roles?
Probably. So they're often drafted extremely broad to say kind of anything you do, whether it's administrative or practicing medicine and seeing patients. That's one of the limitations you probably want to put on is the scope. And even within seeing patients, like if you're doing hospitalist work and you're only inpatient, can I go do outpatient in a more typical setting? Oftentimes we'll see those caveats or those exclusions as well. So it's not just, am I seeing patients or not, but it's also what type of role am I in?
Gotcha. How about if you're in one office and a hospital system thinks that a non-compete area includes all of the offices in a geographic area of the system, is that legal?
Yeah, I think most are going to start out saying that it does apply to every location, every affiliate that they may have. And so with the expansion of health systems and academic centers and even private practices now, I mean, a lot of them have a footprint. That's not just one spot that you're going to be potentially seeing patients at and other spots that they have other physicians at. You want to make sure it's only to where you're working at the majority of the time. So kind of a one dot on the map. Sometimes we'll see 2 if you split your time 50-50, identically between 2 spots. But I mean, think about it. If you've got 7 or 8 locations and all of them have a 10-mile circle around them, I mean, you've got a real problem. I mean, that's 70 or 80 miles. Would a judge think that that's reasonable? I would hope not. It also forces you to go through the process of litigation to get to a judge to find out what he's going to say on it. And so we just think kind of that preventative medicine, right, is solve it up front. It's going to be much less expensive to do that than it is to fight it later on.
So how does this work? Do you submit contracts to resolve in real time as you're negotiating?
Our platform is structured where you can, whenever, if it's 2 a.m. and you're looking at your letter of intent or your contract, you can go ahead and upload it to the site. That'll give you the access to compensation data so you know roughly if you're being paid fairly. It's going to help spot risk in the document so you know if there's kind of these non-competes or other things that are huge red flags. And then it'll also give you the opportunity to connect with an attorney if that's the level of service that you're wanting. So that way you can talk to somebody and get these questions answered. But we certainly want to make sure at least kind of at baseline, you know what's fair and you know what those red flags are. So I think everybody that's in training would be wise at least at looking at that part.
What leverage factors do physicians have?
Well, they should have a lot. So when we think about any market where there's a shortage of something, usually that means that people are competing. And so in this situation, if there's not enough physicians, you should have leverage. You should be able to walk in and make reasonable requests, and those should be listened to. But personally, right, I mean, macroeconomics don't always affect your individual situation. And so there are certainly some markets like, I don't know, you think about a highly desirable area, maybe a San Diego, for example, where in your specialty, they may have more applicants than there are positions open. Even though across the country, there's a shortage, there's not necessarily in that location. So I think you've got to do some personal analysis on it, understand for your specialty, for this location, how much power do I have? And then also, how many offers do I have? Because even if it's an area where there's a ton of demand, if I've only got one job offer, boy, it's pretty hard to push for things too strongly if this is really where you have to be. So that's one of the things that will help you create leverage. And I've said this multiple times, but use resources like PracticeLink. Make sure you've got all the offers for the areas you're interested in, because that just helps you evaluate, but it also helps you give yourself leverage. So it's data points plus leverage on top of it. So that's my recommendation. Evaluate the whole market, and then you'll have a pretty good idea.
Do you often find contracts which specify specific staff will be assigned to support an ambulatory physician? And is this negotiable with large healthcare organizations or private practitioners?
Sometimes. So most contracts have a paragraph in them that talks about just generally kind of the equipment and staff that you're going to be provided. It'll be reasonable. And a lot of times that's enough. That works. We've had some clients, though, that have come in and said, hey, if I don't have X, Y, or Z, I'm not taking this position. These things are so important to me that they're deal breakers. And so what we've seen systems do in those situations and private practice is they'll attach exhibits. They'll do things that are showing that, hey, even though we're going to give you reasonable staff, that means at least one NP, or that means a scribe with you, or it means we're going to buy a scribing technology to come alongside you, or it means we're going to buy certain equipment, an ultrasound machine or a phaco machine or whatever it is, right? Depending on your specialty. We've even had people, at times have like blueprints for offices. So it's like, hey, you don't have office space for me yet. And so you're going to build out this clinic, and I'm in training, which is who we're talking to, and I'm still 2 years out. I trust that you'll have the construction done by then, but I need to see the layout. I want to approve the layout. Now that's rare, right? I mean, we're not usually seeing that, but it can happen. And so I think, again, if those things are important to you and deal breakers, you at least need to ask the question. Whether you push for it as being a must-have in the contract or not, I think is very specific to a person, but certainly should be on the table of the items that you're thinking about.
Let's talk a little bit about locum contracts. I'm sure you're seeing quite a few of those these days. What red flags should people be aware of there?
That kind of falls into that side gig bucket that we talked about before, is people are more mobile now. There's more telemedicine now. And so there's the ability to pick up kind of these locum shifts and gigs at maybe a higher clip than we saw in the past. What I would be careful on, or the first thing I'd be careful on, is just if you're interested in living in that location long-term or working with that organization long-term, most of the locum contracts are going to have some type of clause in them that it's not necessarily a non-compete, but it's a financial penalty. If you walk in and steal the contract, so to speak, and try to contract directly with that organization and cut the locum company out, there's going to be restrictions. So I think knowing what you want out of this long term, I think would be a good step one. Making sure you have control over how many shifts you can take and how you can say no to those things, because this is never usually your full-time job. Sometimes it is for people where they're bouncing between locums, but that's the minority position. So I just think you've got to be careful on knowing how much you're going to work, where you're going to work if they have multiple locations, if you're in like an ER type setup, and then also making sure you don't want to be there long term. If you can solve those three things, the rest of it usually will take care of itself.
Of course, we work with a lot of locums now, and it always seems to be growing. So I think that's something that's definitely not going anywhere anytime soon. What are the potential penalties for leaving before the contract's expiration? And how often do you see that now? Do you see that a lot, or do you hear as younger generations come through the ranks? Is it more common, less common?
We certainly work with clients and talk to clients that are going through an exit. They're transitioning from one to the next, or they signed a contract that they need to get out of because a better offer came through. You have to be really, really careful in those setups, because sometimes you will have terms that are locked in for 3 years, right? There's no ability to get out unless somebody's in breach of contract. And if that's the situation, usually nobody's in breach, right? I mean, for us, it's just like, hey, I changed my mind. Well, that's not enough. And so the financial penalty in that situation would be whatever it costs the employer to go out and find a replacement. So whether that's locum coverage or whether it's a new hire, I mean, we know those things aren't cheap. And so there could be a very big dollar amount that's hanging out there. Now, if you've got What's more typical is that you've got this 60 to 120 day, somewhere in that time frame without cause termination. Your damages are going to be limited, or your risk is going to be limited in those situations to a couple months, but it's not zero. If you're going to breach a contract and leave early, you've got to be well aware of those financial implications because it can be very costly.
What information should someone gather from their potential employer before signing the contract?
Hopefully you're doing a lot of information gathering in the interview process. So I think if you're going to go to work for a health system, for example, I'd want to know when I'm going to work, where I'm going to work, how much call I'm going to take, what type of extra responsibilities are there? Are there administrative duties? Are there leadership duties? Is there medical directorship things I need to be looking out for? What type of APP supervision do I need to get into? I mean, there's a lot there, but it's all kind of the same thing. It's just like, what am I supposed to be doing all day, every day? So that's number one. And I would try to gather that as clear and paint as clear a picture on that as you can to make sure that the contract language mirrors that down the road. The second thing that I think is always important is just turnover rate, is how frequently are you hiring? Because I think that gives you a good window into how they're treating people. So sometimes there isn't perfection in the contract. Sometimes things are vague and you do take things on a leap of faith or you're trusting them. And so I think if there's very little turnover, that's a good sign where they are following through, as opposed to spots that are either constantly filling or they haven't been able to fill for a while. Sometimes that's more of, problematic situation where you want to get those details in writing. So I think if you're asking all those details and then following up with it to document it, I think it'll put you in a better position.
And what about an employer terminating a contract? Do you ever have that? Or do you ever see that? Or what are the termination provisions?
It's pretty rare. I mean, even employers, if there's a problem, it has to be really egregious for them to terminate for cause. So obviously there's some kind of no-brainers, like you lose your license, you're probably going to get terminated. If you have committed malpractice so many times they can't insure you, right? That's another kind of a for cause. Substance abuse, other things that are common sense. But even in those situations, if there's any gray area at all, most of the employers want to terminate without cause. They don't want to go through any type of wrongful termination lawsuit or any dispute on that stuff. And so you're most likely going to get 2 to 4 months notice on any termination by an employer.
Physicians, only want to be contacted by recruiters who know your specific professional interests? Simply call and speak with a PracticeLink physician specialist, and we'll help you create your free profile and pair you with only the job opportunities that you're interested in. Visit PracticeLink.com to get started today.
How about tail coverage? Can you explain that, talk about that a little bit, again, to medical students, residents who may not know what that is?
Yeah, this is one more kind of like non-competes. We'll back up for a second. So when you're getting insurance for patient encounters, there's generally 2 different types. The first type is going to be a policy that's on a what we call a claims-made basis. And so those are covering you for any lawsuits that come in while you're working for that employer. Okay, so patient sues, you're still working there, great, you've got coverage. The other type of policy is what's called an occurrence-based policy. And so an occurrence-based policy just says, hey, we're going to cover your actions. It doesn't matter when the patient sues. So if they sue today, or if they sue 2 years from now, which is probably the statute of limitations, the coverage is there. It has nothing to do with when the claim comes in. The problem with the first type, with that claims-made type, is that if you're not with that employer anymore, you've got to ask the question of, well, who's covering me then? Because I'm no longer underneath employer A. And so if it's a claims-made policy, answer is nobody unless you've bought and tail. And so tail coverage can be really expensive. I mean, it can be a 6-figure number for some specialties. For some specialties, it's more like 20,000, but it's not a zero number. It's not a small number. So knowing who, one, is responsible for that financially, but then also 2, who's actually going to go through the mechanics of picking it up, are really important to know in your contracts. We tell clients, I mean, it could be worth more than your signing bonus in a lot of situations. And so you're going to negotiate the signing bonus. You ought to think about negotiating the tail coverage as well.
Talk a little bit about if there are more campuses opened, things like that, or other clinics opened that aren't part of your original contract. How do you go about handling that? But suddenly it's maybe thrown at you.
Well, that's, again, with the expansion of a lot of the systems right now, I mean, a very common thing where there is a new clinic location. And so if they're going to ask you to staff that, and your contract just says you're going to work when and where we tell you to work, well, then I would say that legally they're allowed to ask you to do that. And you shouldn't be surprised by that request. Now, if you bought a house in a certain location because of where you thought your clinic was, and now the clinic is 40 miles away or on the other side of town where there's a lot of traffic and you're commuting, I mean, obviously that can cause problems. So this would be one of the reasons why two sections of the contract, not only the duties and obligations, right, of where I work is important to get definition on, but also your non-compete, because if they're adding a location that's falling into that non-compete, they just put another 10-mile circle on the map potentially that you got to be careful on. So I think it's one of the reasons why we feel so strongly about protecting those two areas in the contract is that things change and they should change. We expect systems to put a clinic in a new location if it needs to be there. We just want to make sure we know what our obligations are as an individual physician. If I have to go there or if I don't, or if they're going to hire somebody else, that's the part that we're trying to avoid, is any of that discomfort around that discussion.
And what about full-time employment? What would constitute full-time employment? It would vary, I guess, from place to place, or is there a standard answer for that?
I think it depends a little bit on even specialty, right, and location. I mean, sometimes there's certainly health systems that you're working 4 days a week, and that's considered 1.0, 4 days of patient encounters, right, or patient pacing time. There are some systems that think 5 days a week is the requirement. When you talk about a 1.0 FTE or full-time, we often like to see carve-outs for doing that admin work for some of the charting. If you're going to be in an academic situation where you're teaching or doing research, we think those things should be specified and allocated appropriately for what you're after and what you're needing. And so the big one for us is the admin. So even if you're not in an academic center, for example, you're just out in a normal health system setting or a private practice setting, making sure you're protecting at least some of your time to do that work that's needed for the important part of like billing and getting paid for what you're doing. I think that's key to satisfaction, because if you're seeing patients 8 to 5 every single day, for example, in clinic and in the OR, there's not a lot of time to chart and do that other stuff. And so if you can protect even a half a day, like a 0.1 or 4 hours per week, I think that's helpful.
What about students? Do you ever have medical students who come to you who maybe have been approached by facilities to maybe sign a contract or to work with them after residency?
So 2 categories there. From a resident's perspective, the answer is yes. I mean, most residents are signing their contract in their last year. Sometimes, though, even the first couple of years of residency, if you know you're going to a certain location that has an opening, they know it's still going to be open 3 years from now, 4 years from now. We've had people sign very early, and they'll get stipends, compensation, essentially to sign early and to help out financially while they're in training. Take that back a step further to med school. We have had some folks sign in med school. Those are a little bit dangerous. So med school, you don't even have a specialty yet. I mean, you're not matched, and people change their minds still a lot. And so sometimes when it's a rural setting where they know they can use almost every specialty all the time, they're willing to go out and sign med students. But I think what you have to be extremely careful on in that situation is that if you think you're going into primary care, for example, and all of a sudden you want to subspecialize, like I was going to be internal medicine, but I want to go do GI now or cardiology now, and that rural area doesn't have enough patients to support a cardiologist or a GI doc, well, now we're in a really difficult spot, because you may have received $200,000-$300,000 of support for 4 years during medical school. They may have paid off some of your med school loans, things like that. That's usually the enticement to do it so early. And so then you've got this idea of, well, how do I pay that back? Because I want to go do this career in a different specialty that they don't necessarily need or that they can support, but they've already outlaid a bunch of money. So I think you have to be really, really careful when you sign that early, that the contract is thinking about those things and how we're going to handle that transaction if it doesn't work out.
Yeah, I mean, that is something I've seen more and more. And again, it is mostly primary care, family medicine, internal medicine, pediatrics, things like that. And I think a lot of them will work with the hospital in their 4th year after some audition rotations. But again, it's scary because they're not really matched at that point. So something I see more of. People want to kind of grow and keep their own, I guess, grow their own.
Yeah, not uncommon. It's usually going back to hometown. I mean, that's the most common scenario that we see with those situations is, hey, we know you want to come back here. We're going to take you regardless of what specialty you're in. And so let's get the contract done early. But even in that situation, people change their minds. So you got to be careful.
So to wrap things up, what would be the main things that you would say to the listeners today, to people who maybe are at that point of getting ready to start audition rotations, starting to wrap up medical school, and people who are looking at their last year of residency? So what advice would you give those folks?
Well, step 1 would be, if you haven't started looking for a job yet, you need to. So if you're in your last year, get on that part. And hopefully if you're listening to this, you're already on PracticeLink and utilizing that. But step 2 would be there's not a lot of business and medicine training for you. There's certainly none in med school. There's very little in residencies, in most residencies. And so I think you have to educate yourself, and you have to utilize the tools that are out there to make sure you know what's fair, because these contracts are really the first time for most kind of into the real world. And the economics of healthcare, it's big, right? I mean, it's like a fifth of our GDP is healthcare. And so moving from what you're earning in residency to what you're going to earn over the next 25 to 30 years is something you need to take seriously and protect. And so I just think it's great. We love coming on here and talking about this stuff, but I think whether they use PracticeLink or Resolve or anybody else, make sure you're educated and you know what you're getting into, because it's so important to our system to have you guys satisfied and not burning out, that we want to make sure you're taken care of.
Good deal. So we'll wrap up then. Kyle, I would love to invite you back for another episode. On behalf of myself and PracticeLink, we would like to thank you and Resolve for being a guest on our podcast. For our listeners, reach out with any questions you have. You can go on PracticeLink.com and find any of my information, and you can go on Resolve.com and visit their site and hopefully find some great resources and connect with some really helpful people along your journey. Hopefully we can make it a little bit easier for you. Kyle, thank you so much as always.
Appreciate it. Thanks.
Thank you.